So I remember being a very junior liaison consultant about 9 or 10 years ago and seeing Professor Kapoor present a conference on risk assessment, and it's essentially the fallacy of risk assessment. And I remember one of those take-home messages that Nav talked about was one of the very few things we can do to minimise risk of repeated self-harm is to consider following people up in clinic. I remember going back to the team, chatting to Jonathan and thinking, this is serious stuff. We need to really consider how we can work something out within the team. And Jonathan, being Jonathan, ran with the idea, and we're now several years later in really quite a luxurious position in terms of our self-harm follow-up. So I'll let Jonathan take it away, but it's lovely to be on the programme with Nav. Thank you.
Thanks, Vish. So to give a brief bit of background, so this presentation is around the self-harm follow-up clinic that we've run in Sunderland since around 2014. Sunderland is a 1,000 bedded hospital. It's a big city centre hospital. PLT in Sunderland do somewhere in the region of 5,000 to 6,000 assessments a year, with about 50% of those from the emergency department, and probably about 70% or so of those emergency department assessments being linked to some sort of self-harm, suicidality, or patients in crisis. So PLT in its current guise was commissioned in early 2014. Prior to that, in Sunderland, we had a small, what was termed a self-harm team at the time. And then there was a bit of an explosion in funding in 2014. We got lots of new staff. We got Vish as a full-time consultant in post. Our current team is made up of 24 Band 6 nurses, which do predominantly the assessments, front of house and back of house. We have myself as a nurse consultant. We have 3 Band 7 clinical leads. We've got 2 full-time consultant psychiatrists and various other staff. So we're quite a big service. And I joined the team in January 2014, just as we expanded. And quite quickly, as Vish says, we realised that there was probably a little bit of a gap in service provision for that cohort of patients that presented to the ED with self-harm, quite often an overdose, or sometimes not even active self-harm, but thoughts of taking an overdose or thoughts of suicide. And PLT are commissioned to get down and assess a patient within an hour, which is great, but what that means is sometimes patients are still distressed, dysregulated at the close of assessment. And we always said it would be nice just to see patients in another 2 or 3 days to make sure that the plan we put in place is safe, that things haven't got 10 times worse. You know, referring somebody into primary care counselling doesn't really plug that gap because they have long waiting lists, as do secondary care mental health services. Community treatment team takes 2 to 3 months to do an assessment with somebody, and then a waiting list which is much longer than that. GPs are overrun, and there's a bit of a variation, if I'm honest, in GPs around their interest in mental health and their expertise in mental health. So we thought, why don't we set up our own self-harm follow-up clinic where we try to see people within a few days of initial assessment and see how it goes. So before we did that, I had a bit of a look at what evidence-based there was behind this, and there wasn't a great deal. So we had NICE Clinical Guideline 16, which was short-term follow-up for self-harm in that first sort of 2 or 3 days. But that was written in 2004, which predates liaison teams looking like they currently do. It predates a lot of the universal crisis teams that we have. And then following that, in 2011, we had Clinical Guideline 133, which was around the longer term follow-up in self-harm. And that suggested that there's some evidence that psychological therapy, specifically structured for people who self-harm, can be effective in reducing repetition of self-harm, and these should be 3 to 12 sessions. So we used that and we said, what can we do then? So we set up 2 face-to-face clinics per week with 4 sessions in each. And if I remember rightly off the top of my head, one was on a Monday, one was on a Thursday, and they had 4 one-hour slots in each clinic. We were fortunate at the time that we had a nurse who was trained in full DBT and another nurse that was trained in solution focused therapy. So going back to that clinical guideline 133, about 3 to 12 sessions of intervention, we thought, why don't we roll out some DBT informed skills in one clinic and some solution focused therapy informed skills in one of the other clinics, and just see how it goes. We kept some basic outcomes in the early days around things like length of time to follow up, DNA rates from clinic, the type of self-harm that patients had been assessed for prior to coming into clinic. And we did this for about a year, and it had some good points and it had some not so good points. And some of the feedback we got from patients was that it was twofold really. It was either that these 2 or 3 or 4 sessions of brief intervention around DBT or solution focused therapy confused them more than anything. And I think DBT in particular, DBT is obviously, you know, 12 or 18 month therapy, and just trying to dip in with a bit of distress tolerance work and a bit of mindfulness for some patients just confused them more than it helped. For some other patients, they actually said the opposite. They really enjoyed it, but they felt it got kind of cut off just as they were getting into it and just as they were finding some benefit. And the clinicians that ran these clinics, their feedback was actually they felt the real benefit was just that ability to review someone 2 or 3 days post-assessment to look at, review their risk. Had risk increased or reduced post-assessment? Was the discharge plan and the safety plan we put in place at point of assessment still relevant? Did anything need to change with that? And just to give some TLC really, and go back over what initially happened prior to that episode of self-harm. Is there anything else we can do to help? And quite often patients would turn up to this face-to-face clinic with an appointment letter that said, come here on this date at this time. And when we would ask, you know, can you remember what we talked about at our initial assessment? Can you remember the plan that we put in place in the emergency department? Quite often they would say, no, the only thing I can remember is I've got this letter to come and see you in 2 or 3 days time. And they couldn't remember that we'd suggested a referral into counselling services or drug and alcohol services, or we potentially made a prescribing recommendation to a GP. So it also allowed us to revisit that plan again. So with that in mind, and the fact, because one of the other challenges was actually when we only had 2 nurses able to deliver DBT informed therapy and solution focused therapy informed therapy, it was a challenge when we had staff who ended up rotating on the night shift, or they were on annual leave, or they went on sick leave. So we thought, why don't we review it and change it up slightly? And in around 2015, 2016, we increased the number of clinics we offered. So we changed it to every Monday, Wednesday and Friday. We offered 6 sessions on each of those days. So that was 18 sessions a week. We dropped the DBT and the solution focused therapy, and we just focused on that more pastoral support, getting a robust safety plan in place, revisiting the risk assessment and the discharge plan that we put in place. By doing these clinics every Monday, Wednesday and Friday, it kept us in line with the guidance on 72-hour reviews for patients that are discharged from psychiatric hospitals, because there wasn't any formal guidance around within what time frame patients should be followed up following discharge from an acute hospital. But we thought it probably is, it's not dissimilar evidence-wise, in that if somebody's come into an acute hospital, they've taken a big overdose, they've been on the wards for 2 or 3 days, and then they're discharged home, we know in psychiatric hospitals there's a spike in suicide rates on day 2 and day 3. So it stands to reason that there's potentially going to be a similar risky period in that first 72 hours. So every patient we now see within Sunderland Royal Hospital in the emergency department following an episode of self-harm, or even patients who haven't self-harmed but have had thoughts of self-harm or thoughts of suicide, we follow them up within 72 hours. This changed the clinic and then allowed us to just use all of our band 6 staff on rotation. So they all got a chance to be part of clinic. It was face-to-face, like I said before, and we had a roughly 66% attendance rate, which wasn't too bad, and compared well to some of the attendance rates with our community teams. And the anecdotal evidence was that the majority of those patients we followed up in clinic, there was a minimal requirement for those patients to be escalated into the care of the crisis team or to need a psychiatric admission. And by and large, a lot of those patients, whatever had driven them to self-harm, that initial assessment, things had often resolved, whether there'd been drugs or alcohol on board, whether they'd had an argument with a friend or a family member, whether they'd had some bad news. 2 or 3 days following that initial assessment, which I think in itself is a good intervention, just getting that assessment within an hour in the ED often helps bring people down off the ceiling. And then to revisit that 2 or 3 days later is enough to contain a big group of patients and stop them hitting crisis services or coming back to the ED again with further self-harm. So fast forward to 2020 and COVID hit with a bang. And I'm sure everybody on this call had changes to their working practice during COVID, and it was no different to us. We couldn't really justify doing 18 face-to-face contacts a week during the early days of the pandemic. So what we did was we replaced all of those face-to-face contacts with telephone contacts. And it was supposed to be temporary at first, and we were all, I think as everybody was, waiting for COVID to end. But that seemed to drag on for 2 and getting on for almost 3 years now. And I think we're probably at the point now where COVID is as ended as it's ever going to be. And the feedback around switching from face-to-face follow-up to telephone contacts was the staff found this helpful because it was more flexible, and actually we got through to more people on the phone than patients who had to present face-to-face. And the attendance rate went up to, I think the last time I checked, it was about 70 or 75% of patients that we could contact on the phone. The cons from telephone contact were some patients were a little bit more difficult to engage, and I think it's often easier when you're sat face to face with somebody and they can't get out the room, that you can really engage them in a good, robust conversation. And you can also assess somebody's mental state, I think, much more robustly face to face than you can over the telephone. So going back to last year, we started to talk as a team, myself, Vish, and Imogen, who's our research lead in the team, and I know Imogen's on this call. We had a bit of a chat around what does the future hold for our clinic. It's kind of done well so far. We knew that the new NICE guideline for self-harm was coming out soon, so we were eager to see what that said, but we thought, can we get ahead of the curve a little bit? So we had some discussions around who exactly is the self-harm clinic for, because self-harm is a very broad term, and we see patients in our liaison team who self-harm 7 days a week with zero suicidal intent, and they do it as a means of regulating their emotions. So for that patient group, what is the intention of clinic? Is it realistic that somebody with that presentation who potentially has lots of trauma in the background, and there's a lot to unpick there, are we going to make a significant impact on their self-harm behaviours in a one-off follow-up? On the same spectrum, we have those patients who come in who've never self-harmed in their life, but they've potentially taken a one-off overdose because they've had a really difficult day, or there's been a build-up in stresses. And again, what's that self-harm clinic for? Is it around making sure that they don't self-harm again? Is it around giving them the tools to make sure that they don't self-harm, or they don't attempt suicide again? So we had lots of conversations about that. We acknowledge that the NICE guidance was well out of date now, so going back to that 2004 clinical guideline 16, that was about 17 years old now. After a bit of digging, we found the Cochrane Review on Psychosocial Interventions in Self-Harm, which was originally published in 2016 and updated in 2021. But the challenge with implementing longer term interventions in self-harm from our service is that we weren't really commissioned, and we didn't have the ability really to keep people on for 6 sessions or 12 sessions of follow-up, especially when, as I said before, we do somewhere in the region of 3,000 assessments in A&E every year. And as I also mentioned before, the challenge with getting patients referred into primary and secondary care services to potentially help with this is that they have long waiting lists, and then you're breaching that ability to get follow-up into patients within 2 or 3 days. So at the time, I was going into the final year of my Masters in Advanced Clinical Practice, and my dissertation needed to be a systematic review. So I thought, why don't I kill 2 birds with 1 stone and do my systematic review on brief interventions and rapid follow-up in adults who attend the emergency department with self-harm. And this was my PICO for that systematic review. So we looked specifically at adults because kids automatically in our locality get a follow-up post self-harm from our ICTS service or Children's Crisis Team service. I use the intervention as rapid, meaning within 7 days, and time limited, as in 4 sessions or less than 4 sessions, intervention post self-harm. And the outcomes we were looking for in that systematic review was that there was a reduction in further self-harm post intervention, reduced suicidality using I think it was a Beck scale, and reduced depression, which was also a Beck scale. So that was a really interesting systematic review, and there wasn't a great deal of evidence out there looking at this rapid and time limited follow-up. There's an awful lot out there for longer term interventions, or interventions, you know, 2 weeks, 3 weeks, 4 weeks post self-harm. But that real quick turnaround, which is obviously now in the new NICE guideline, there wasn't a great deal of evidence. And I think I ended up pulling off around 10 or 12 papers, and I whittled those down to about 6, which were all quantitative papers, which just made it a little bit easier for me to compare and contrast. And what I found was that there were papers from lots of different areas around the globe. So I think one was from Canada, one was from Australia, one was from Sweden, one was from Norway. The interventions contained in those trials were very variable in that one of those trials focused solely on safety plans. One, the intervention was phone calls. Another was brief psychological intervention in a face-to-face contact. Another service used letters and postcards to send out to patients. None of those studies were repeated, and the difficulty in kind of generalizing any of the evidence that we got from those studies was there was massive variations with the healthcare systems those studies were carried out in. Some were private healthcare systems, some were public healthcare systems. The safety plan trial was done in a veterans hospital in I think it was Canada off the top of my head. So what they showed was actually, yes, self-harm follow-up is useful, and it does help reduce further self-harm, and it does help reduce rates of suicidality, and it does help reduce rates of depression. But it didn't really help with giving us in Sunderland any guidance on what our service should look like. And I'm conscious of time, and I'm nearly done. So in the last couple of weeks, we got NICE Guideline 225, which is the updated NICE guideline around self-harm, which is fantastic, and it includes an awful lot of the stuff that we've been banging the drum about in our service for the last 9 or 10 years. And the new guidance suggests that if there are ongoing concerns with a patient following a self-harm assessment, then they should have aftercare within 48 hours of assessment, which I'm glad to say we probably already meet in Sunderland. That we should offer a structured person-centred CBT informed intervention that is specifically tailored to people who self-harm, and that this should start as soon as possible, is again within 4 to 10 sessions, and that we should consider developing a safety plan. And that last point again is what we already do with our patients. So just before I finish, a slide or two. Sunderland liaison team is in the early stages of being part of a clinical trial called SafePit, which is the brainchild of Els Guthrie out of Leeds. And this is a low intensity therapy for patients who have been assessed in the ED following self-harm, but are not chronic self-harmers, so it must only be between 1 to 3 episodes of self-harm. There are 12 trial sites. We've got 2 or 3 therapists on our site, and we need 80 participants, 40 of which will be the intervention, 40 which will be treatment as usual. And I'm really excited about this because actually, if this works and we get good outcomes from this, then this will meet this recommendation in the most recent NICE guideline, and it might be that we can just roll that out in our 3 clinics a week. So we will see how that works in the next 6 to 12 months. For now, the future of the clinic in Sunderland is that we are standing up face-to-face clinics again, and we're probably going to have a blended approach, and that will offer patients face-to-face follow-up, telephone follow-up if they prefer, or there's a third option as well in that we use e-consultation where you can contact people via Teams or Zoom. We are making a real push around safety planning in our team at the minute. We've just bought some tablets so we can take them up to the wards and we can complete electronic safety plans, which we can directly upload to the patient's online record, and then email them a copy as well. And actually alongside that, our Trust CNTW is doing a big piece of work around standardising safety plans and getting a standardised template on our mental health record system. One of the most recent innovations in the locality is that we now have PCN nurses working into GP practices. So those are mental health nurses, either band 6s or band 7s, that are picking up patients with mental health needs or self-harm needs across various GP surgeries in Sunderland. And I've had preliminary discussions with their lead around whether those guys might be able to help pick up some of this work as well. They might be able to support us with some of that self-harm follow-up. And the final point is, I think we need to get better, and myself and Imogen are doing some work around this, of just auditing the good work that we do and looking at outcomes. And it might be as simple as we just do a core 10 when we're sat in front of a patient in A&E, and we do another core 10 3 days later or 2 days later in clinic, and see if that's improved. Or do we just do a PREM, a patient reported experience measure, or do we have to dig a bit deeper and do a really kind of longitudinal dig into the data and see if this clinic is helping reduce reattendance rates to the ED with self-harm? It's probably not going to be a quick piece of work, but I certainly think it's a worthwhile piece of work. And that is us.